Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.
Welcome to this evening's edition of the Lung Cancer Living Room. Tonight, as many of you know, we will be talking about biomarkers and new targets in lung cancer. Welcome to those of you who are familiar with the Living Room, and for those of you who may not be and are just joining us for the first time, I'm Danielle Hicks. I'm Chief Patient Officer here at the Go-To Foundation for Lung Cancer. And the Lung Cancer Living Room is a support and education series created specifically with patients and caregivers in mind, with the goal of bringing to you live in real time educational talks from key opinion leaders, such as Dr. Stephen Liu, who is a MD, Associate Professor of Medicine, Director of Thoracic Oncology, and Director of Developmental Therapeutics at Georgetown Lombardi Comprehensive Cancer Center. So we have a very exciting program planned for you tonight, where we're going to be talking, like I said, about biomarkers and, more importantly, new targets. And some exciting things have been happening over the last maybe 3 or 4 weeks, some new approvals. Of course, ASCO, the American Society of Clinical Oncology, just wrapped up. And so there was some really great information coming out of that, which you'll hear more about in next month's Living Room when we do the best of ASCO. So welcome to all of you. Thank you for joining us. Before we get started, I'm going to ask Bonnie Adario, who needs no introduction, but again, we always like her to say a quick little hello, and then we'll drop over to Dr. Liu. Bonnie? I think you're on mute. The little microphone should be green.
Got it. We're good. Yes, just welcome, Stephen. You know, we're thrilled to have you here tonight. I don't want to take up any more of your time than necessary to, talk to all the people that are dialed in here. So that's all I have to say right now, but I'll be popping in and out as the evening moves on. Thank you.
That's great. And I think I'll add a little bit to that. So Bonnie is not only a 17-year survivor of stage 3B non-small cell adenocarcinoma, but she's the co-founder and chair of Go-To Foundation for Lung Cancer. So as always, we are excited to hear her and what she has to say tonight. Dr. Liu, with that, I'm going to turn to you and ask you to tell us a little bit about yourself and why you chose lung cancer as a primary area of focus.
Sure. Well, thank you for having me. I really appreciate the invitation. It's great to be here and talk. My name is Stephen Liu. I'm based at Georgetown University in Washington, D.C. I've been here since 2013. Prior to that, I was at USC in Los Angeles.
Oh.
And when we think of choices for lung cancer, a lot of our career path, I think, is a little arbitrary and just by chance. I think that there are a lot of things that drew me to lung cancer. One is, the potential for impact. A lot of the research I did early in my career in training was focused on prostate cancer. But when you step back and look at overall outcomes and where we are with the disease, while there's still very important work being done in prostate cancer, the 5-year survival for prostate cancer is 99%. It's kind of hard to do better than that. And when you look at lung cancer, one of the most common cancers in the world, when we started, that 5-year survival rate was around 11, 12%, which was just so sharply different. And that was so striking to me. And the potential to make an impact, the potential for improvement was so great. For lung cancer, my experience there in training was very different from some other cancers. You have someone that has a very serious, sometimes fatal, lethal disease that can move very quickly. And, each step needs to be very measured. You need to be very quick to establish a rapport with that patient. And that journey that we go on, it sort of starts in a very intense circumstance. And I find that the bond there that I have with my patients is just so much stronger. And And like I said, a lot of it is a little arbitrary and has to do with mentorship. And when I was at USC, Barbara Gitlitz, a very close friend of mine, now was very, and yours, very enthusiastic, sort of infectious with her passion for advocacy and for moving things forward. And when you're in training, I think the people that you're training with and their love for certain types of research really rubs off on you. And that's where we are today.
That's great. I think Barbara Gitlitz, as Bonnie just said, has been a friend of the foundation for a long time and no stranger to the go-to lung cancer community. And after tonight, I know you will not be a stranger to this community in a really large way as well. So before we get into discussing these, new targets, I want to start with a little bit of background on how we determine if a patient diagnosed with lung cancer has a target. When we're talking here about biomarkers, and as I tell patients all the time, biomarker testing comes by many names, and everybody calls it something different, right? Whether it's molecular testing, genomic profiling, comprehensive profiling, like all of that. So let's start very basic about what is a biomarker and what are we looking for when we test for these.
Yeah, so this is the most important piece of information to obtain once we have a diagnosis of non-small cell lung cancer. And while it's exciting at meetings to focus on the therapeutics, first line, second line, resistance, none of that matters if you don't make that first step properly. So what is a biomarker? There are a lot of definitions, but for lung cancer, a biomarker is a measurable characteristic of the cancer. And we're usually talking about either proteins on the outside of the cancer or changes to the DNA on the inside of the cancer cell, which is usually what we're focused on. And like you mentioned, there's lots of different names. They're describing the same thing: molecular testing or profiling, genomic testing, mutation testing. They're all describing the search for certain mutations, certain biomarkers. And these biomarkers tell us about the biology of the cancer. What is fueling this cancer? How did it come about? What's making it go? What is driving this cancer? And when we find these changes, we call them driver mutations. And when it comes down to it, we are trying to identify something that cancer is relying on, something that makes it different, that it needs to exist, to thrive, to survive. And if it's important to the cancer, it's also a vulnerability. And so we try to target that context of vulnerability because maybe we can take it away. And so biomarkers tell us about prognosis. They tell us about the biology and the patterns of spread. That's all useful information. But most importantly, they guide proper therapy from the very beginning. And some of the biomarkers we're looking for: mutations in the EGFR gene, fusions or chromosomal rearrangements, same thing in the ALK gene. When we find these, we have very effective and generally well-tolerated therapies, but it has to be the right match. So if we have an EGFR mutation, we can start an EGFR inhibitor, and the vast majority of patients have a rapid, durable response. But that exact same drug in a patient whose cancer doesn't have that mutation, the chance of response is 0%. So we can't guess. We have to know, and we really have to get it right the first time.
Yeah. One of our mantras is don't guess test. And too often we see, especially in the community, that these docs are only testing for one or two or three of the potential targets.
Yeah, you only can find what you're looking for.
Yeah. Right.
So right now, not only have we talked about lung cancer being many diseases, but when we're talking about biomarker testing, who should be getting biomarker testing?
It's a good question. Kind of depends on who you ask. In my opinion, anyone with non-small cell lung cancer should get biomarker testing. But I would say overall, it's most critical for a patient who has a stage 4 lung cancer, and it would be considered the standard of care today for anyone with non-squamous histology, which is most lung cancers. It should be considered in squamous histology as well, and many institutions, many clinicians, myself included, would test regardless of histology because some of these targets are seen in different histologies, and again, when they're there, it makes such a difference when you find them. There's more recent data over the past year or so that biomarker testing may guide your treatment options in earlier stages as well. To me, this is critical information, right? Our philosophy here is know thy enemy. The more we understand the cancer, the better we can treat it. We want every advantage we can get. And so I'm testing everyone with non-small cell lung cancer.
I think that's great. And you touched a little bit on that earlier stage patient, because historically we are looking at the later stage patient, or had been looking at the later stage patient to do this biomarker testing on. And we've had conversations at the living room in the recent past, and quite a bit actually over the next year, based on exactly what you're talking about in this earlier stage patient, particularly as it pertains to the Adura trial and some of the results coming out of that. And I know it's not on the agenda for tonight to talk about, but since we kind of brought it up, can you talk a little bit about what that trial showed us and what is sort of happening since then?
It's an important, it's an important study, and it does open up this whole can of worms that we need to address, but we have to address it, and it's going to make a difference. The Adora study was a randomized phase 3 trial that was led by our colleague at Yale, Dr. Roy Herbst. He presented these data last year, and what it showed was in patients who had resected lung cancer, so a curable lung cancer, an earlier stage, this was stage 1B to 3, that had a complete resection, so all their tumor is gone, could have received standard chemotherapy if appropriate. And at that point, the standard would be to watch, to observe only. And in this trial, if patients met those criteria and their tumor had one of the common mutations in EGFR, an exon 19 deletion or an exon 21 L858R point mutation, if you had one of those common sensitizing EGFR mutations, you were randomized to receive osimertinib, which is an EGFR inhibitor, once daily for 3 years, or a placebo pill. And what they looked at was how likely was that treatment going to prevent the cancer from coming back. The study was designed to detect a 30% reduction in the risk of the cancer coming back. And what they showed at an early look was an 83% reduction in the risk of the cancer coming back early. They had to unblind the study. They had to announce the results earlier than anticipated because of the dramatic difference. When I look at that study, there are some critiques. It hasn't yet shown a difference in survival. And my answer to that is that takes time. And I need to make a decision now based on the data that we have. We saw this drug was very well tolerated. And one of the striking pieces about this study is our standard treatment of surgery, chemo, and observation isn't really that good. And patients with an EGFR mutation in their cancer, those cancers came back quickly and in most patients. And so a reminder that even though for some cases we're hoping to cure, with the standard treatments, it's not necessarily our expectation. And especially in a stage 2 or a stage 3, the chance of recurrence is very high. And what we learned from that study is giving a targeted drug early on prevents that from happening. Now, what will happen, a few years after you stop the pill, what will happen 5 or 10 years from now, we don't know. And we'll have to look at and see how these data mature. But to have something reduce the risk of a cancer coming back by 83%, over the first few years, I think there's tremendous value in that, especially when the treatment's so well tolerated. So based on that, the FDA approved osimertinib for resected EGFR mutant lung cancer. That was in late 2020. And now if someone comes in with a resected cancer, it would be important to test them for EGFR to see if any of those mutations are present, to see if this is potentially an option at least available. And, in lung cancer, I never shy away from the information. I want as much information as I can have. And then I sit down with the patient. We discuss how to use that information. But if you're not looking, you're never going to find it.
Right. Yeah, I think it's so important, and thank you for touching on that. I think most folks out there at early stage don't actually realize that with these resectable or folks who do qualify for surgery, upwards of 40% of them will recur, right? And so we're trying for multiple reasons, but to have this sort of as a back pocket option for the patients who currently, are in the EGFR realm is really sort of setting the stage for what this might look like with other targets, right? And the research that still needs to be done with some of the other biomarkers. So thank you for talking a little bit about that. So I want to touch on something next that Bonnie mentioned a little bit ago, and that's the difference between doing, what for, to put into lay terms, sort of a limited panel versus a comprehensive panel. One is one or the other preferred, or is one or the other preferred in your opinion?
So it's a very good question. A limited panel really means that our testing is limited to a small number of genes. And we're usually talking about single gene testing, where we have a list of genes that we want to interrogate, that we want to test. And we kind of check them off like we're ordering sushi. A comprehensive panel is like ordering the whole boat, where you're just going to get everything all at once. Now, a single gene panel seems like it'll be less expensive. And that's true if you're only ordering a couple. But once you order more and more single genes, it actually becomes a little more cost efficient to order them all at once, sort of ordering in volume. And we are well past that tipping point where we have enough genes to look for that it makes much more sense to do comprehensive testing. I would only order a limited panel if really there were one or two specific things I was looking for. For most patients, and really my entire practice is comprehensive testing. Cover all your bases, including a lot of the rarer targets. And because you're doing all the testing at once, you're more efficient with using up that precious tissue biopsy, making it less likely that you're going to run out of that tissue. The limited testing, the single gene testing, sometimes it's not even comprehensive in that test. And so if you order an FDA approved test for ALK or test for EGFR or KRAS, you may not get all of the EGFR mutations. You may not get all of the KRAS mutations. You may only be testing for a certain amount of those. So comprehensive testing, in my opinion, is much more useful. In addition, limited testing, it's usually DNA. And some of the more modern panels, including what we use at Georgetown, test both DNA and RNA. And there are a lot of specific targets like ROS1, like Exon 14, where RNA is just a better test. And my general philosophy is if we're going to do it, if we're going to do testing, we should do it right. So I want to send comprehensive, state-of-the-art, full testing right up front.
So you mentioned, sorry, were you going to say something?
I was just saying thank you, Stephen, for explaining that so comprehensively.
Well, I think that when people talk about comprehensive testing, the only what's the downside of doing comprehensive testing? It's not getting more information. The downside is cost. The downside is cost. And if when I talk to colleagues, say I really don't want to order this big test, I say if it were free, if there were no cost to anybody, would you order it? And it's always yes, 100%. Well, then why should it be any different based on that cost? And I think the cost of getting treatment wrong is much greater. First of all, one dose of something like immunotherapy pays for everyone's testing. And secondly, the biggest cost to me is time. Because if you're giving a treatment that's not working, you're losing time, which really is priceless. And to me, cost, if that's the only reason not to get comprehensive testing, to me, that's not a good enough reason.
No, to me, that's no reason at all. It's just, yeah.
Yeah, and I think we could have an entire, living room, conversation around barriers to biomarker testing, and cost obviously being one of them. And the question being, well, what do you do, in a situation where, maybe a comprehensive test isn't covered, and or the patient can't afford it, or like how do we handle that? Anyway, I don't want to drive us or fly us down some rabbit hole about that, but I think we're driving the point home that comprehensive biomarker testing is sort of the way to go in this subset of patients, these non-small cell lung cancer patients. I think one of the things I want to touch on here before I jump onto the next question, because it just kind of came to mind, and we're going to talk a little bit about the targets that have been identified and that do have FDA approved, therapies for them. But when we're looking at this comprehensive test, there are biomarkers that may not have currently approved therapies, but might have clinical trials. Can you talk a little bit about the importance of, or the role that clinical trials, might play in this arena?
It is so critical. Clinical trials, it's much more than just advancing the field as a whole in an altruistic sense. In many cases, a clinical trial is the single best option for a patient. When we have a drug that works, that I know in my hand, this is a good drug, it's well tolerated, it's very likely to work, we have to realize it would take years for that drug to become commercially available and approved by the FDA, because that's how our machinery works. To the FDA's credit, we're getting better. and things are moving faster, but there's still a lot of time between that first signal that this is a really good option and an FDA approved drug. In many cases, the only way to access those drugs is through a trial. And there are all types of different clinical trials. A lot of us think of clinical trials as sort of a last ditch, very low chance of working. I think in many cases, those days have gone. And what we're looking at in 2021 is really the era of precision medicine, of rationally designed drugs, where we know exactly the type of cancer we're treating, where we know exactly where that vulnerability is. And we have medicinal chemists designing drugs that will specifically work if this specific vulnerability is present and won't work anywhere else. It's not a random guess, hope that it works. It really is something that's planned and thought out and should work. And that's something very different. And when clinical trialists, like Dr. Gitlitz, like myself, when we're looking at these different trials, when they make it this far, there's so much invested in them. In a lot of cases with these trials, it's something that I really expect to work, not something that I'm hoping it works, but something I really expect to work.
So I kind of hear you saying, like, today's clinical trials, and we ironically had a conversation about this very early this morning, about clinical trials not being your grandfather, your great grandfather's clinical trials, right? Where a lot of patients are fearful of them because they're thinking they're going to get a placebo or a sugar pill versus, a trial drug, when in actuality, patients are most often getting standard of care, right? What they would normally be getting outside of the trial versus what is a trial drug.
Absolutely right. All these trials undergo very strict ethical review, and there's a lot invested in these studies, and we will not run a trial unless we believe there's a chance to be better than what's out there. And so at the very least, you should be getting the standard treatment with the option to get something that could be better. And these are things that we need to talk about. And, trials are listed on clinicaltrials.gov, which is a very comprehensive website. But really, it's a conversation with your oncologist and with other specialists in the area to talk about what those trials are. And gone are the days where I heard about some secret trial that's being run at this university. We're very open. This is an academic community. We all want the field to move more quickly. We know what trials are out there. We know what new drugs are coming along. We talk with each other. We're sharing information. And so getting access to these newer drugs early, I think, is very important to getting to the best possible care up front.
So I think one of the things I'm hearing you say that is an important piece of this clinical trial sort of conversation is that sometimes the best first-line treatment for one of your patients is an actual clinical trial.
Absolutely correct. Absolutely right.
We're gonna jump into the next question, but I'm also gonna plug the foundation really quick and let those of you watching know that we have a program that we in-house and externally call Lung Match, and it's a treatment and trial navigation. So if you are looking for a clinical trial and wanting to know whether or not you might qualify for one, and or if there's one in your area, you can absolutely reach out to us on our helpline. And we can connect you with these treatment and trial navigators, because I know we talked about clinicaltrials.gov, not an easy thing for most patients to navigate when they're trying to look and see and do their Google searches whether or not they qualify. So I'm just going to give a little plug to us there. So we've done some talking about that. Next question I have for you is, does this testing have to be done on tissue? What is sort of the gold standard, and what does this look like from a tissue biopsy? And then we'll jump into this sort of liquid biopsy and talk a little bit about what that is.
Well, tissue is the gold standard for now. It's evolving, but right now that's how we're making a diagnosis. I think now I would view biomarker testing really as part of the diagnosis. We know that lung cancer is very different from breast cancer, but we also know that an EGFR mutant lung cancer is very different from a BRAF mutant lung cancer. They behave differently, they have different mutations at their core, and they really should be treated differently. In my mind, those are different cancers. But to answer your question, the biomarker testing standard right now would still be on tissue.
So, liquid biopsies are sort of new to the game, within the last couple, years. Can you talk a little bit about what role Let me step back before we jump into liquid biopsy. So patients, one of the barriers, because we kind of touched on it a little bit ago, sometimes is tissue acquisition, right? Or getting enough tissue or good quality tissue. That's been a barrier. Can you talk a little bit about tumor heterogeneity and like some of what that might look like, and why we're sort of moving into this liquid biopsy space?
Well, tissue is sometimes difficult to acquire. Sometimes tumors are in difficult to locate places, and there are certainly risks with a biopsy. We're putting a needle into an organ, and there are risks with that, depending on where that tissue is. We're getting a little better. It's been a big shift in thinking. When we go back, not even that long ago, 10, 15 years ago, 10 years ago, the point of biopsy was to make the diagnosis with as small a needle as possible to make it as safe as we could. And so you're using the tiniest needle to minimize the risk. We see a diagnosis of cancer, that's all we need, and then we back out and do as little harm as you can. And back then, it didn't really matter once you had a diagnosis beyond lung cancer because it didn't have a whole lot of treatments. Now we need this comprehensive genomic profiling, so we need more tissue. And to use a larger needle may increase the risk for that procedure, but it is definitely much safer than doing another biopsy or having to go back and do it multiple times and avoiding the delays that are associated with that. But when we do a biopsy, we're putting a needle into a certain area, into one small part. And in some cases, that may not be totally representative of the entire cancer. We may miss certain areas. Some are a little different than others. And that's one of the potential advantages to doing a liquid biopsy, as you alluded to.
So let's talk a little bit now about go ahead.
About progression. About progression and a blood-based biopsy.
So before I jump into progression, because I know there's I've been talking to a lot of folks lately about this liquid biopsy space and when it's typically used, right? Is it used as a companion diagnostic at progression, to see maybe what's going on, folks who may not be healthy enough for a tissue biopsy? Can we talk a little bit about what a liquid biopsy is and sort of how they work, and then where they're currently, for the most part, being used?
Yeah, so great important points. First of all, being completely underutilized, in my opinion. Now, liquid biopsy is the other way to find mutations. Liquid biopsy refers to detecting ctDNA, which stands for circulating tumor DNA, or cfDNA, cell-free DNA. Basically, it's DNA shed from the tumor into the blood. As these cancer cells are dying off and being replaced, they're breaking down their DNA, it's being released in the blood, and we can pick that up now. We have the technology to identify those mutations in the blood. A couple general principles. The test is specific, meaning if we find a specific biomarker, we believe that it's there. If we find an ALK fusion in the blood, we believe that ALK fusion exists in the cancer. If we don't find anything in the blood, we don't believe that. We believe a yes, we don't believe a no. If we don't find it in the blood, it might just not be shed at the same rate. It might be in too small of a quantity to detect. So if we don't see anything in the blood, then we have to wait for the tissue. So it lacks some of the sensitivity. Advantages of the liquid biopsy are that we're sampling the tumor as a whole, whatever DNA is being shed. Potential disadvantages, in theory, if there were two cancers at once, we wouldn't be able to tell which came from which. An advantage is that it's faster. A tissue-based biopsy test, if I have the tissue in my hand, I'm running next-generation sequencing, probably going to take about 2 weeks to get those results, whereas a liquid biopsy would be half that time, if not even shorter. So faster results, downside, potentially an additional cost. So weighing the pros and cons, in my mind, again, they are complementary. And there were some studies done from UPenn with Dr. Charu Agarwal and Dr. Josh Baumel that show that when you're doing tissue and liquid together, you are catching more mutations. You're seeing more if you do both together. They are complementary. And I think, as I mentioned before, everyone would do them if they were complementary. And if we just take cost out of it, I think that the liquid biopsy really adds a lot at the time of diagnosis. So on our institution at Georgetown, we send both right away. When I first meet a patient, we send liquid right away, and we're doing tissue at the same time because, again, I think they build off of each other. Now, you mentioned using those at the time of progression, and that's also critical But it's important to remember what we're looking for. If there were no mutations on full comprehensive testing at the beginning, no mutations present, and we do treatment like immunotherapy, and then we see the cancer starting to grow, not responding to that treatment, in that setting, repeat biomarker testing probably won't shed a whole lot of light onto things. It's not necessarily the wrong thing to do, but maybe not really going to give us a lot of information. If you start with a driver mutation, if you start with a biomarker positive cancer, then at every step of the way, testing is going to give you valuable information. Because if you have a biomarker and you start a targeted agent, if you have EGFR, you start an EGFR inhibitor and it's working and you're still taking the medicine, and then the cancer starts to grow or a new spot pops up. If we didn't change the medicine, then the cancer must have changed itself. Something's different. So if I'm seeing growth, something's changed. And if you can pinpoint exactly what has changed, then you can adjust your treatment and try to cover that back door that cancer is trying to slip through and restore control of that cancer. So again, information is our friend here. And every time that cancer is changing, I want to know exactly what's changed. How has it changed so that I can rationally change my treatment as well?
Yeah, I
David
think
Gandera always responds to that as, what's driving the bus now, right?
Very
yeah,
good way to put it.
Yeah, exactly.
Yeah, he does. I just want to recap sort of before we move on for folks watching when it comes to this tissue versus liquid, and Dr. Liu and others that you've heard talk at the living room, and I'm sure in other places are talking about, doing this at the same time when it's feasible, and knowing it's not always feasible for everyone, but if you can find it in the blood, then you can be fairly certain, if not very certain, that it's there. But just because it doesn't show up in the blood doesn't mean it's not there. So that's why sometimes we have to wait for the tissue biopsy results to come back. And then again, at progression, cancer, sadly gets sort of smart and figures out what's blocking it and how to work its way around it. And so knowing what that workaround is for the cancer is also an important piece in determining what the next treatment is. Did I capture that?
Absolutely correct. Well said.
Okay, great. So, in your opinion, how important is it that patients wait for this biomarker testing for the results to come back before starting treatment? Because I know, as I'm sure you do, that patients are anxious and they find out they have cancer and they want to get started on trying to fight the cancer right away. So how important is it that we wait?
Yeah, it's absolutely critical. And I'm glad you asked this question. This is a really tough one. And I completely understand when you have a diagnosis of lung cancer, you do the research and you realize this is a serious condition. This needs attention. And maybe there were some delays in diagnosis. Maybe you've had these symptoms for a little while before someone figured out that this was lung cancer and there's an urgency to it. And I'm not here to minimize that. I appreciate that. And I agree with that. But we aren't looking for the fastest treatment. We're looking for the right treatment. We're looking for the best treatment. If we find a biomarker and we match it to the right treatment, our chance of success is very high. Almost all patients will have some response, some benefit. These responses occur very quickly. They can be very deep, they can be durable, and they can be effective in areas of the body that are normally challenging to treat, like the brain. So finding a biomarker means that you're finding a very appealing treatment option. But these biomarkers don't only help us select for a targeted therapy, they help us to deselect immunotherapy, which we hear a lot about and is a very important type of treatment. And, there are patients that have long-term survival, even cure with immunotherapy that I see in my clinic every day. But lung cancers that have one of these biomarkers do not tend to respond well to immunotherapy. So if we start immunotherapy before we have the biomarker, we may be, frankly, giving the wrong therapy, a treatment that has no chance of working, while a treatment that will work is just sitting on our shelf. And the sequence is actually very important. And this is something that's new for oncology. The stakes are really high. If we start with a targeted drug, they tend to be very well tolerated, generally few side effects, very safe. But if we give immunotherapy, even a short course, and then we give targeted therapy, it suddenly becomes much more dangerous. We don't totally know why. We suspect immunotherapy is reprogramming our body's immune environment, and it changes the way we react to these medicines. But some of these side effects can be very dangerous. So there are some patients that need to start therapy very quickly because of symptoms, because of location. And in those settings, if I need to start treatment today and I don't have the biomarkers, that treatment is chemotherapy, because we can walk back from chemotherapy and still move forward safely. The same's not true for immunotherapy. So that's why it's important we get that biomarker testing done quickly so we can make sure we're giving the right treatment and giving it in a safe way.
And I'm so glad you said that about chemotherapy. If you could just spend a moment telling the patients that are listening that chemotherapy is a good drug.
Yes. So chemotherapy is very different from chemotherapy before. And I have a lot of patients where at a certain time, chemotherapy really is the best treatment, and there's a natural aversion to it. And I think it's in part because of what we see in movies and media, or because of family members we know that were treated a long time ago. And one of the most important advances we've made over the past 2 decades haven't been the specific chemotherapy drugs, but a lot of the supportive medicines that we give to prevent the major side effects from chemotherapy. If we look at adenocarcinoma of the lung, this is the most common lung cancer. The most common chemotherapy used would be carboplatin and pemetrexed. And those are drugs where generally patients would not expect to lose their hair. Most patients will not vomit or throw up even once, where we've gotten very good at managing or minimizing the side effects. And I don't want to say that chemotherapy is easy. I would never say that. It is, nothing about this is easy. I'm not here to minimize that. But I also want patients to appreciate that you're not meant to suffer through this. That if we go back to the 70s and 80s, you kind of had to choose between sort of suffering and still getting treatment, or not suffering and not getting treatment. You don't need to make that choice. That's not supposed to be part of that. My job is not to make cancer smaller. My job is to improve the quality and quantity of patients' lives, and making people sick through it is not part of it. So if we do start chemotherapy and someone does have side effects, someone reacts poorly, then it means that I didn't give it right, that I gave too much, or that I need to make some adjustment, because suffering's not supposed to be part of it. And if something goes wrong, we need to adjust. We need to make sure that doesn't keep happening.
I think it's really important that you're talking about all of this, because quite often over the years in talking with patients, they'll mention side effects of therapy, and we'll say, well, have you talked to your doctor about it? And they're saying no, because I'm afraid he or she is going to take me off my therapy if I let them know that I've got X, Y, or Z side effect. And I think it's really important to drive home exactly what you're saying, and that is that there are highly effective drugs available to these people to counteract and manage those side effects, and how important it is to talk to your healthcare team about it.
That's the most important part. You have to have a good rapport, good communication, because why sort of needlessly suffer? Why tolerate things? And that happens too much. And I really try to push. If someone says I'm doing fine, really try to push. Sometimes I'm asking family members, watching things, because some people do feel you have to suffer through it. You have to tolerate it. You have to put on, but that doesn't have to be part of it. In fact, I would actually argue that it's counterproductive. That if I have someone that's getting a treatment and they're having a lot of side effects, not telling me, they're not going to be able to tolerate it longer, and will end up having to stop treatment because it becomes unsafe. Whereas if a patient tells me early, I can maybe make some adjustments to make it so much easier to improve the quality of life now, but also to allow us to continue this treatment maybe much, much longer. So I think it's everyone's interest if we're just very open, just tell me what's going on. And if there's something that I can't really make better, then we can make a decision together about whether this is something we can tolerate or not. But you have to have these open lines of communication. And it's a little tough because we've only got short times with each patient, because the clinics are busy. You only have a little bit of time there. But those are messages that have to come out right away. You just got to be very open with your team.
Yeah, I agree. And I think this is where, at Go-To Foundation, and Bonnie can attest to this, for years and years, this is why one of our main goals is to educate and empower patients, about all things, but this is a really big thing. And I think it's one of the things, because of that sort of limited window that you're talking about, we can help, right? So if you call us, we're sort of an extension of your team. If a patient calls us to talk about this, we can set them up with questions so that they can have that conversation with you. And, that shared decision making sort of conversation is such a big piece of
Yeah.
it. So, yeah.
We're not here to replace you as a physician, but we are here to educate patients so they know those questions to ask you. And we don't tell patients what drug we think they should take, although sometimes it's kind of hard not doing that. But we don't do that. We're here to have the discussion we're having now, and getting you to say all of these amazing things to the people that are listening right now.
Yeah, absolutely. So next, and I'm trying to keep an eye on the clock here, and I know we've got about 20 minutes left, and I really want to get into some of these new targets and how it really is an important milestone, in particular one of them, when it comes to treating lung cancer patients. But I want to ask you really quick. We've talked about biomarkers, and we've heard EGFR and ALK. I think have been the two that have sort of come up repeatedly as we've been talking. But how many identified mutations or targets, as we've called them, currently have FDA-approved therapies?
For lung
Roughly.
cancer, right?
For
Because
lung cancer. Yes, sorry, yes.
right, so we have EGFR, but there's a lot more granularity with EGFR now. There's the common EGFR mutations in deletion 19 and exon 21 LA58R. There are atypical, less common EGFR mutations like exon 18 G719X. And then more recently, just within the past few weeks, the EGFR exon 20 insertions. And so there's a lot of granularity. We have different drugs approved for those different types of mutations. EGFR is not just yes or no. We need to know the specific mutation that's there because there are different drugs approved for those different mutations. We have approved drugs for ALK, which is fusions, for ROS1 fusions, for BRAF V600E mutations, for NTRK 1, 2, and 3 fusions, for MET exon 14 mutations, for RET fusions, and for KRAS G12C. HER2 mutations are coming, not yet approved. And we do have some general biomarkers for immunotherapy, like PD-L1 expression, microsatellite instability, maybe a little less relevant for lung cancer. But those would be the lists today. If you ask me in 6 months, it's going to be there'll be even more, I promise you.
Yeah, absolutely. Go ahead.
I just said, which is great news. Things are moving, and patients know that. They know that if one drug is failing them now, there's another one out there, and then there'll be another and another. And as long as these keep working, the research will keep moving on.
I agree. And I think this is where it's a big yay and hand clap and shout out. And if I had, a whistle, I'd blow it for clinical trials and why it's so important based on this amazing conversation we've had about sort of this knowing your cancer and the importance of this biomarker testing, because long gone are the days when it is just an EGFR mutation, right? And the submutations under that EGFR are so important. And without this biomarker testing, we don't know what that is. We don't know whether or not a clinical trial, to your point, Dr. Liu, might be the best first line treatment, or if there's already one with an FDA approved therapy. So with that, I want to start talking a little bit about KRAS. I mean, KRAS, when I entered this sort of lung cancer space and dug my heels in from a caregiver and then an advocacy perspective, KRAS was something I heard about a lot, right? And back then in 2003, 2004, although they looked for a KRAS mutation, it was mostly so they knew what not to do, not so much what they could do. And now we have some things that we can do. And KRAS, and correct me if I'm wrong, but it represents roughly 30% of the mutations in the space that we've been talking about. And then we've been talking about sort of these submutations. And so not unlike EGFR, even under KRAS, there's a submutation identified as G12C. And we got some great news, some exciting news to come out around that. Can you talk a little bit about what's going on in KRAS?
Yeah, I think you summed it up perfectly. KRAS is one of the more common mutations, but biologically, it's very different from the other biomarkers in terms of its effect on the cell. And as a result, it's been very challenging. We can't block it the same way that we're blocking EGFR, ALK, and ROS. And, for decades, it was considered undruggable, but there have been some advances. We're specifically talking about KRAS G12C. Just the nomenclature, if you're curious, it's all biochemistry. So KRAS refers to the gene. G12C means that at codon 12, what is normally a G, which is a glycine, has now changed into a C, which is a cysteine. And so that one change really has turned a normal cell into a cancer cell. So that G12C represents about half, maybe 40% of the KRAS mutations overall. So if we do the math, it's about 13% of all adenocarcinoma of the lung will have a KRAS G12C, which is a pretty big number. We can also see it in squamous as well, though it's pretty rare, but we can see it in squamous too. There are a lot of different KRAS mutations, G12V, G12D. Our focus is on that most common one, G12C, where we have a new drug that was recently approved, and that's a drug called sotorasib. Sotorasib is a drug that binds directly to that C, to that cysteine residue. So it's not going to work at all in a KRAS G12D because it binds to the C. It has to work in a G12C. So knowing KRAS positive is not enough. Like in EGFR, you need the details. We need the specific mutation. And if you're doing a test like PCR, that's not going to tell you whether it's a C or a D. So you need to know exactly what type of test you're doing. Another case to do comprehensive testing up front. But sotorasib is a drug that's really changed things. This is a drug that was recently approved by the FDA in a huge unmet need for us. Our treatments for KRAS have been immunotherapy and chemotherapy, and that's it. But now we do have a targeted agent approved here. It's a big response. So I can tell you a little bit about some of the data if you'd like to hear it. Sotorasib was studied in the CodeBreak 100 trial, and this was updated at ASCO by Dr. Nando Skolidis. Sotorasib is an oral medication, and it showed a response rate, a chance of response of about 37% in this study. Now, 37% to us is actually a pretty good number. If we look at stability or control of the cancer, we push that up to about 80%, but the chance of significant reduction was about 37%. And the responses were fast. They occurred usually within 1.5 months, and they were durable with a median duration of response of almost a year. And importantly, it was very well tolerated. While there was some changes in some of the blood values and liver tests, and they can see diarrhea, only about 4% were severe diarrhea. Overall, it's a pretty well tolerated drug. That response rate of 37%, to us, it's actually a pretty good number. It's not nearly as high as what we see with EGFR, with ALK, but our standard option for KRAS was chemotherapy with a response rate more like 20%. So we're almost doubling the response rate, and it's so much better tolerated, and it can work for so much longer. Right now, research for KRAS is looking on newer combinations, see if we can get that number higher and better biomarkers, more complex biomarkers, so we can kind of pinpoint that even more to know exactly precisely where to use the drug in the future. But this is a major milestone to have a drug approved for KRAS, a huge unmet need, and there are more coming. And again, this is a space where clinical trials really are important, where this drug showed a lot of promise even a year ago, but the only way to get it was through a clinical trial. I've known that this was really the best option for KRAS G12C for the past year. And so if this were a year ago, really the only way to get access to what I think was the most exciting drug was through a clinical trial.
And do you see this working even better on a newly diagnosed patient that's never had any other kind of treatment and they have this first line?
It's a very good question. Okay, so these are the tough questions. All right, so should we use it in the first line setting? If we gave it in the frontline setting, would the response rate be higher? It probably would be higher. And generally, that's the theme we see, that when we move drugs earlier and earlier, for various reasons, the numbers look a little better. But now that this drug is approved, will I use it as drug number one? And I probably won't, because even though that response rate is important and impressive, and I want that number to be as high as possible, it's maybe not the most important number for me. maybe the most important one would be, how likely are we to be alive with our cancer under control 5 years from now? And will this targeted drug, will sotorasib, will it give me a chance to have this cancer under control at 5 years? Will that chance be better than something like immunotherapy? Because unlike some of the other targeted agents, KRAS mutant lung cancer can respond quite well to immunotherapy. And I know that I have patients in my own clinic that have a KRAS mutation that received immunotherapy that are now 8 years out, no evidence of cancer. That's sort of the power of immunotherapy, that durable, meaningful, intense remission bordering on a cure. And we can achieve that, not for everyone, not for most, but for some with immunotherapy. And to me, that's really the appeal of immunotherapy and why today immunotherapy is still my frontline option. The KRAS drug may have a higher chance of response. It may, but I don't think the response will be as durable as we see with immunotherapy. One of the things that we're looking at now is combining those and really seeing if we can give these targeted drugs with immunotherapy, maybe get the best of both worlds. And these are strategies, again, trials that we're trying to develop to see if we can sort of marry those two concepts together.
To boost the
Yeah. Yeah, I think
Exactly.
I think talking about the combination therapies and what's sort of coming up in that space, it is important. And again, pointing back to clinical trials and the importance of clinical trials. If you folks watching live, or you folks who are going to come back and watch this post live haven't heard enough about clinical trials and the importance of them tonight, then I don't know what's going on. But and correct me if I'm wrong, Dr. Liu, but the new drug that we're talking about for KRAS was actually only approved after a first line therapy. Is that correct?
That's correct. So the approval is after prior therapy. In that study, when we look at that 37%, patients had a lot of treatment. 81% had prior chemotherapy and immunotherapy. But the drug is approved after initial therapy. So, either immunotherapy or chemoimmunotherapy. After that, I think this becomes a good option.
Yeah, and I think it's important for the folks who are watching who maybe were diagnosed prior to this approval and didn't have the benefit of a clinical trial, but did have biomarker testing. If you know the results of those and it is a KRAS G12C mutation, then it's definitely something to talk to your doctor about. And again, we can help you with the questions that need to be asked around that, and or help you to take a look at what your biomarker result report might look like to determine whether or not you have this. So I think that's fantastic. Thank you so much. The next thing I want to talk about, and we touched on a little bit earlier, and I think Bonnie brought it up, and I think Dr. Lee brought it up, is this Exon 20 mutation in EGFR. What's going on in that space?
Yeah, it's a frustrating mutation. It's more common in non-smokers, just like the common EGFR mutations that we talked about. We have these common mutations in EGFR that lead to a cancer where we have oral therapies that are very effective and well tolerated. The EGFR exon 20 insertion, it sort of leads to cancer in a similar way in a similar type of patient, but those same drugs don't work as well. And like the other EGFR cancers, immunotherapy is also not effective. So you have this EGFR mutation that is driving the cancer, this exon 20 insertion, it's driving the cancer. It's a potential vulnerability. It's different. But we don't have a targeted drug that was effective, and we don't have immunotherapy that's effective. So, basically we're forfeiting all the advances we've made in lung cancer over the past 10 years, and we're using basically chemotherapy. And that's very frustrating. It seems antiquated. It doesn't seem right. But that's where we were for a long time. That finally changed this year when we saw the first approval for an EGFR exon 20 insertion.
Such huge, great news, and I think those happened within a week of one another, if I'm not mistaken. Those approvals, and it was just absolutely fantastic news for so many people. I want to jump. We've talked about immunotherapy, whether in combinations or not, and talk a little bit about IO. And there's been a lot of direct to consumer marketing when it comes to immunotherapy. We've all seen the commercials, right? And I've received phone calls. I'm sure your patients ask all the time, like, "Oh, I want IO. I want IO." How do you determine who might be a good candidate for this type of treatment?
So, immunotherapy is generating a lot of excitement. I think justifiably so. It's a very important type of treatment. And as we talked about, the importance here is really the durability, the potential for a durable response, where if we can train our immune system to recognize and fight that cancer, that's something that it can remember how to keep doing even after we stop therapy. And this is how we can get those durable long-term responses. Right now, the most important thing is to determine whether a biomarker is present for targeted therapy. Because as we mentioned, not only does that tell us targeted agents will work, it also tells us that immunotherapy is much less likely to work. So it's sort of a negative predictor. So I think the most important determination of whether immunotherapy is appropriate is to see whether targeted therapy is appropriate first. And if targeted therapy is appropriate, we'd send us down a different path. It's really a different type of cancer. If we don't have a biomarker, an actionable biomarker, then immunotherapy really is our standard treatment. Everyone with advanced lung cancer that doesn't have a driver should receive immunotherapy unless it's not safe to give. Now, there are many different ways to give immunotherapy, and that can be based on certain biomarkers like PDL1. PDL1 stands for Programmed Death Ligand 1, and this is a protein, a receptor that's on the outside of the cancer. And so we can test the cancer cells to see if they have this protein there. And if it's in very high levels, then we have certain options to deliver immunotherapy. And if it's not present at all, we still deliver immunotherapy, but we give it maybe in a different way. So immunotherapy really across the board, these biomarkers are going to tell us how best to deliver it. And there are other features as well, the histology of the cancer, the location, the symptoms, really a complex decision that the patient and the oncologist make together. But those biomarkers will help us guide how we deliver immunotherapy. But if no driver is present, it's immunotherapy, period. Just how we deliver it's different.
That's great. And I think, we spent a lot of time talking tonight about the non-small cell lung cancer space, particularly adenocarcinoma, although we've touched a little bit on squam. What role does IO play sort of across the board in lung cancer? So we're talking about whether it's small cell, regardless of type of
Yeah.
non-small cell. I mean, is that what I'm hearing you say?
Yeah, it is really, as you put it, it's across the board. So certainly for non-small cell, if there's no driver mutation, if there's no biomarker that we can act on, it's immunotherapy in one form or another. For small cell lung cancer, advanced stage, it's immunotherapy with chemotherapy as our standard of care. For mesothelioma, it is immunotherapy, dual checkpoint blockade for immunotherapy. We're now seeing evidence immunotherapy can be of benefit after surgery. For resected lung cancer, this was data just presented a week ago from Dr. Heather Wakely, showing that after surgery, immunotherapy helps keep that cancer away. Work that was really driven by Dr. Barbara Gitlitz, who we talked about. So immunotherapy is playing an important role across the board for lung cancer, as long as a biomarker is not present. We really got to think of that as a totally different type of cancer.
Right.
I love that.
Exactly.
Thank you. Thank you so much for
Yep.
clearing that up. Again, being mindful of time. And I know when we chatted last week or the week before, Dr. Liu, and a little bit earlier in the green room, as I like to call it, before this broadcast, we could have taken any one of these different things that we talked about tonight and turned it into an hour-long conversation. And I genuinely hope that once the world opens back up, that you will come here and join us live in our living room, because we would love to have you. And before I go to housekeeping, I just want to see if you have any final thoughts that you'd like to share with the community.
Yeah, I think that, really what we started with, and that's biomarker testing is critical to forming a treatment plan. And if we don't have full, comprehensive, proper testing, we can't be confident we're giving the right therapy. There are different ways to test. The field is moving very quickly, so it's important to have these discussions. I welcome these discussions with patients, but we want to be very open in talking about them. But while we spend so much time focusing on the different types of immunotherapy, the different drugs, how to approach those, that first step has to be right, or else everything after that is going to be off track.
Yeah.
Absolutely.
I
Absolutely.
radio
Final
show
thoughts on
in
that?
it today, and they asked me at the very end of the show. They said, if you only get one thing to tell the audience right now. What's the one thing you would tell all those lung cancer patients out there to do? And I said, okay, I'm going to cheat. I have two. One is early detection. We really have to ramp that up, because the best way we can get our lung numbers up is early detection. I said, but then the second thing is they all have to be offered genomic profiling. We need to know what's driving the cancer.
Yeah, absolutely.
Absolutely. Absolutely. Well, I can't thank both of you enough for this conversation tonight. And like I said, we welcome you back, Dr. Liu, anytime. For those of you still watching and haven't yet joined our lung cancer living room community, please go to gotofoundation.org/living room, and you can sign up and get all kinds of good goodies and notifications about what might be coming next in this space. For those of you who haven't heard and maybe new to the living room, Bonnie wrote a book. And it's called The Lung Cancer Living Room, Community of Courage. And that book highlights 20 different stories from lung cancer patients, not only living but thriving with lung cancer. So if you haven't had a chance to take a sneak peek at that book, please also, you can go to the foundation at gotofoundation.org/book and get your copy there. Up next, July 20th is our next living room. It's going to be Best of ASCO. We talked a little bit about ASCO at the beginning of this meeting, the American Society of Clinical Oncology, where all things lung cancer and all cancers actually are being discussed. So please join us with Dr. Pasiane from Dana-Farber Medical Institute. We'll be talking about all the great data that has come out of that meeting. As always, our events, I want to give a shout out because we are increasing our reach into the community. So we have our registration open for our annual Summer Jam virtual 5K. It's virtual this year. It's on June 26th, so it's coming up quick, but it's not too late to register. So if you're interested, the cool thing about this virtual piece is that you don't have to be in a city where we're hosting a live event. You can join from anywhere around the world. So please go to summerjam5k.org to check that out. I want to give, again, a huge thank you to Dr. Liu, all of you watching live, or those of you who will come back post-live to watch this event, Peninsula Television, the entire GoTo team, Michelle Zay, who I know a lot of you out in the community know, who's behind the scenes of this living room. Thank you for all your support. And then, of course, to those who support us in order to be able to bring this to you every year. A special thank you to Amgen, AstraZeneca, Bristol Myers Squibb, Daiichi Sankyo, Foundation Medicine, Genentech, Lilly Oncology, Merck, Novartis, Regeneron, Sanofi, and Takeda. All those names and all those big names that I'm sure some of you may have heard about really believe in this program, obviously, and continue to give us their support year after year. So a huge thank you to them. With that, I will say goodnight to everyone, and we hope to see you next month.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see.